In this video, we'll discuss mood disorders. Mood disorders are characterized by massive disruptions in mood and emotions that can cause a distorted outlook on life and impair the ability to function. So we'll discuss major depressive disorder and bipolar disorder. So for major depressive disorder, according to the APA, depression involves a depressed mood most of the day, nearly every day. It's going to involve a loss of interest and pleasure in usual activities. The symptoms may include weight loss or weight gain, increased or decreased appetite, difficulty falling asleep or too much sleep, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or guilt, difficulty concentrating, indecisiveness, and suicidal ideation, which are thoughts of death. Thinking about or planning suicide, a suicide attempt. The symptoms are going to cause significant distress and impair normal functioning, and they're not caused by substance abuse or another medical condition. And these symptoms, you need to have at least 5 of these symptoms for at least a 2-week period. Depression affects around 6.6% of the U.S. population each year and 16.9% of the U.S. population in their lifetime. It's more common in women than men, and it does appear to have a genetic component, with relatives that have a family member diagnosed with depression having double the risk of developing the disorder themselves. Identical twins have a 50% concordance rate, meaning that if one identical twin is diagnosed with depression, the other twin will end up with a similar diagnosis at some point in their lifetime, 50% of the time. Fraternal twins have a 38% concordance rate. It is often comorbid with anxiety disorders and substance abuse disorders. Bipolar disorder involves mood states that fluctuate between depression and mania. And since we already discussed depression on the last slide, I'll discuss the manic symptoms here. So manic episodes involve inflated self-esteem or grandiosity. And this is inflated self-esteem, but it's unjustified. Self-confidence. A decreased need for sleep, being more talkative than usual, a flight of ideas or racing thoughts, talking loudly, rapidly, abruptly switching from one topic to another, distractibility, taking on several tasks at once, maybe too many tasks, engaging in risky behaviors, and being excessively irritable. And this little kind of infographic shows you the depressive states on one side and the manic states on another. If a patient has experienced 3 or more of the symptoms on the previous slide most of the day, nearly every day, for over at least a 1-week period, and the behavior and level of functioning is uncharacteristic of the person's normal state, they may be experiencing a manic episode. If the episode lasts less than a week, but at least 4 consecutive days, they may be experiencing a hypomanic episode. Now, if a patient has experienced at least 1 manic episode, they meet the criteria for bipolar 1 disorder. If a person has been diagnosed with at least 1 hypomanic episode, followed by a major depressive episode, they may meet the criteria for bipolar 2 disorder. So hypomania is more anxiety and agitation are the primary symptoms. And each type occurs in approximately 1% of the population. Now, if you're diagnosed with bipolar 1, because you've had a full-blown manic episode, they'll never downgrade you, I guess would be a way to saying it, to bipolar 2. However, you could be diagnosed with bipolar 2 because maybe at first you've only experienced a hypomanic episode, but then later on you have a full-blown manic episode. You would then get re-diagnosed with bipolar 2, or bipolar 1, sorry. And there is heritability to the disorder. Genes increase the risk but do not cause the disorder. So some of the same genes that predispose people to major depression also predispose them to bipolar disorder. Genes increase the risk, but again, do not cause the disorder. Twin studies and adoption studies suggest that the heritability basis for bipolar disorder, based on identical twins having a 67% concordance rate, while fraternal twins only have a 16% concordance rate. People that have a relative that has bipolar disorder are 9 times more likely than the general population to get a diagnosis of bipolar disorder. And 2 genes appear to increase the probability of bipolar 2 disorder. So we'll just talk a little bit about mood disorders in the brain and what we know. So mood disorders often involve imbalances in neurotransmitters. In particular, serotonin and norepinephrine are often implicated. These neurotransmitters involve bodily functions that are disrupted in mood disorders. And many medications that are used to treat bipolar disorder often increase norepinephrine and serotonin. And they do this by either blocking reuptake or enzymatic breakdown of those neurotransmitters. Now, for bipolar disorder, treatment often involves lithium. Now, how lithium stabilizes mood is unknown. Almost all neurotransmitters have been suspected or implicated in one way, but that includes serotonin and norepinephrine, as well as dopamine. So I've also seen it suggest that lithium might actually decrease the inflammation of the brain, that perhaps is an inflammatory process that causes the bipolar disorder. And just to briefly discuss this diathesis-stress model of major depressive disorder. So the idea is that stressful life events often precede the onset of a depressive episode. However, not everyone who experiences stressful life events develops depression. So this suggests that perhaps there's a predisposition or vulnerability that could be involved. This predisposition could be genetic, early childhood trauma, or some other situational or personal factor. And then a life stressor comes along and combines with that to reach the threshold of depressive symptoms. So again, you have your diathesis, some sort of predisposition. Then you have, and this could be a gene, this could be something that's happened to you in early childhood, something along those lines, the way you were brought up. Then you have stress, maybe the loss of a loved one, and those two things together result in the diagnosis of major depressive disorder. Your text discusses a serotonin transporter gene. However, that work can't be replicated, and more recent research suggests that it's a combination of genes that is probably the predisposition or the diathesis for major depressive disorder and potentially bipolar disorder.